Good morning to all my Angelman family and friends. I'm Dr. Robert Carson from Vanderbilt Children's in Nashville, where I now direct the Angelman and 15Q clinic. The goal of the talk today is just to update you on some of the work we've been doing to better understand movement disorders and Angelman syndrome. As this audience well knows, there's a variety of movements, some abnormal, some not, in Angelman syndrome that can be quite disruptive. They range from the more benign and normal stereotypies or stereotypical movements, the happy dance, if you will, to tremors, and of course, seizures, ataxia, and then non-epileptic myoclonus. Really, the goal at the onset of our work was to really better understand non-epileptic myoclonus. And of course, through better understanding, we can better develop therapies that help mitigate it. So one of the key challenges I think as a community we face is that we're trying to make sure that we're all talking about the same thing. For example, I'll often point out to students when we're teaching that I use the word spells a lot. And the purpose of using a more generic term is to not put a name to something before we fully understand what it is. So given that we're discussing abnormal movements, which don't necessarily fit the classic abnormal movements described in the literature, this has been a bit more challenging. Much of the work today on non-epileptic myoclonus has been out of Ron Thieber's group in Mass General. And the working definition are paroxysms or episodes of myoclonus, mostly in the hands, can involve the legs as well. These can last from seconds to hours to all day, and I think our data reflects that as well. And relevant to this audience is that this is something that increases as our children age, affecting greater than 60% of Angelman patients beyond 35 years of age. And again, as you're aware, this can be very disruptive. Some families report that it impacts their child's ability to swallow, to walk or talk, and they cry and get upset when these happen. So the approach we took to better understand these movements is to collect survey data and to collect video data. And at the time that we started, this was, of course, right in the middle of the COVID pandemic. So we were trying to design a study that was user-friendly, that limited the need to travel, and that people from a variety of locations could participate, as well as capturing videos in people's home environment really reflects day-to-day life versus what we would try to do or trying to capture an event specifically while you're in the clinic. And part two of this is that we plan to have a subsequent library available. So I know I'm going to be talking about movements, and it's sometimes, a picture or video is worth 1,000 words. You're going to get the 1,000-word version today. But in the future, we hope to have a library available so everybody can look at video examples and say, oh, that's an example of a seizure, that's an example of myoclonus, etc. So far, we've had a total of 47 surveys that we've collected and videos that we've analyzed from 20 patients. And I think the key initial point that we'll come back to is that we have, in my opinion, learned a lot from the initial data, including thinking about potential interventions. And some of this are things that will probably not be shocking to this audience, but abnormal movements seem or may respond, or at least our data suggests get worse when people are constipated, when they're awake or have not had good sleep, and with worsen around the time of periods in some of our women patients. Now, one of the challenges that we face going through this data is that for many of the patients, so we had 47 patients, but a total of 103 abnormal movement types reported. So what that means is for some patients, we had 2, 3 to 4 different types of movements checked, some of which sounded very similar by description. So that made it harder in some ways to separate out what different movements we're talking about. So what I plan to do today is just to talk about a subset of patients for which we also had video data. So what we've been able to do with that data is we had multiple videos representing 20 patients that were reviewed either individually or sometimes in groups by 10 movement disorder specialists. Now, interestingly or not, some of these discussions, people had different opinions on what they would call this. And so that is something to be aware of, and it's just the reality of the clinical world we live in. Now, of the 20, I'm going to focus on 16, and the 4 that I won't focus on were 3 children who had stereotypical movements, again, the benign things, the happy dance, if you will, and 1 infant who, upon video review, we thought these looked more like normal baby movements. So we did not associate any pathology with that, the youngest of the patients. So as I mentioned before, there wasn't agreement between everyone on what to call some of these movements. And I think one description was that they were pleomorphic. So that means they weren't purely myoclonus, they weren't purely tremor, but maybe a mix of these different types. Now, one of the, I think, the interesting findings that is going to be really important in the future is that of these 16 patients, in 9 of them, the primary movement disorder type was felt to be dystonia. We'll talk a little bit more about that, but this is a movement disorder which heretofore was not commonly appreciated as part of the Angelman syndrome phenotype. So going back to these 9 patients with who their movements were felt to represent dystonia, the most common label for these patients were in 6 out of 9, so 2/3, the families described these as tremor. And then the next most common was that they look like jerks. These were mostly seen in the hands and arms, but often affected the face and the legs. Almost everyone remained awake and alert during these spells. A few were slowly responsive, and 1 patient was reported to be not responsive. And like many of the other movements we see between patients, the frequency of these events and the duration was quite variable. Though I note that in 4 of 9 patients, they reported that these spells could last all day long. So clearly, these can be quite disruptive. As we discussed before, the triggers for many of the abnormal movements, including dystonia, are similar. So stress, standing, constipation, menses, fever, and being excited were all things reported to make it worse. Rest and sleep were reported to make things better. When we specifically talk about medications which might help, the only treatments that fall into the category of making it much better or better, well, in this case, I'm talking about those that just were reported to be much better, were, of course, the class of medicines, the benzodiazepines. So this includes clonazepam, lorazepam, diazepam, and then another medicine called trihexyphenidyl, which I know I've discussed before. For the 4 subjects that reported using trihexyphenidyl, 1 reported no benefit, 1 reported being better, and 2, the family reported that they were much better. And given that this is a medicine that is commonly used to treat movement disorders, these findings do make sense. So just kind of taking a step back and bringing this all together, I think, you know, the more I talk with movement disorder specialists, I think I realize that these movements are complex, and they often demonstrate more than one phenotype. I do think that the more discussions we have, the also more movement disorders specialists may be getting an additional interest in Angelman syndrome, which is always a good thing. The 2 major phenotypes that our data reflects really represent non-epileptic myoclonus, and then the second phenotype would include dystonia or a dystonic tremor. So a tremulousness that looks like a tremor, but is really more related to the dystonia. And again, as I'm just describing this in words, but as we move forward, we hope to have the video examples available, not only for you as families, but for providers, so we can all kind of hope to get on the same page of thinking about what are the types of movements we are discussing. Of course, I would love to say today that I have the magic bullet that will make all movement disorders go away in Angelman syndrome. And I think the one thing that everyone can do now that I think may help is to be aggressive with what you're already doing. And that means working on constipation, continue to explore options to improve sleep. And then if your child is a woman, and definitely if symptom exacerbations correlate with the time of her period, then hormonal therapies may be an option that could have important benefit. Obviously, as we explore our data more and think more broadly, we may be able to come up with other treatment options. But I think what another step you can do in the meantime would be capture videos of these movements. And these are things that you can bring to your local provider to help them understand what you are seeing at home. And I will add that you know, I do believe that dystonia is a part of what we're seeing, these abnormal movements in Angelman syndrome. And so it may be something most parents with Angelman syndrome have been doing for a long time, which is also educating your local providers on Angelman syndrome. And that may mean suggesting, like, here's a video. There's been discussions about whether some of this could be dystonia. Does that change how we might try to treat it? So my apologies. So thank you all for listening. And of course, I would like to throw out additional thank you to the Angelman Syndrome Foundation, and specifically the families who have both supported this work, and for all the families who have taken the time to submit survey information, as well as submitted videos. So thank you all. Hope to talk to you all shortly. Have a great day.